This will be a continuation of your discussion on increased intracranial pressure. We'll be talking about one cause of your increased intracranial pressure, and that is your cerebral edema. So class, your cerebral edema is the increase in the volume of the brain due to the abnormal accumulation of fluid, which could be in the ICF or the ECF of your cerebral tissues. Now, when I talk about cerebral edema, okay, there could be several causes for your cerebral edema. One, it could be vasogenic. When I say vasogenic, this is increased capillary permeability that leads to plasma leakage into the interstitial space of the brain's white matter. Okay? So class, your vasogenic is usually brought about by the increased permeability of your blood-brain barrier. And again, when I say about increased permeability of blood-brain barrier, this is usually brought about by inflammatory and infectious processes in the meninges. Because normally, your blood-brain barrier would not be allowing for the passing of substances, okay, through it. However, class, with the damage brought about by your inflammation and your infection, okay, your blood-brain barrier would increase in permeability, resulting to the leakage of plasma, okay, on the spaces of the brain white matter. Then you have your cytotoxic. Class, your cytotoxic is due to intracranial hypoxia or ischemia, and the changes in the functional or structural integrity of the cell membrane. So here we're talking about your cell membrane. Cytotoxic edema, class, would result from osmotic imbalance in the ECF. And your cytotoxic edema would usually affect your gray matter. Okay, just as a point of comparison, the vasogenic edema would usually affect the white matter, whereas your cytotoxic edema would usually affect your gray matter. Now, you have your interstitial or hydrocephalic cerebral edema. So for your hydrocephalic cerebral edema, it is result of your extracellular fluid accumulation in the periventricular white matter. Okay, so the focus of your interstitial hydrocephalic cerebral edema is the interstitial fluid that would be eventually reabsorbed through the arachnoid villi. So take note, it is periventricular. When I say periventricular, that will be surrounding the ventricles of your brain. That's why your interstitial edema would have a high possibility of reabsorption through your arachnoid villi in comparison to the other two, your vasogenic and your cytotoxic. Okay? So again, to differentiate the three, your vasogenic is caused by increased permeability of your blood-brain barrier, also because of your blood vessel problem. Your cytotoxic, on the other hand, as the term implies, cyto, okay, so this refers to your cell, okay, resulting to an osmotic imbalance and commonly occurring in the gray matter. Whereas interstitial would be occurring in your periventricular white matter and has the possibility to be reabsorbed through your arachnoid villi. So these two would be able to differentiate between cytotoxic and vasogenic. So in your cytotoxic class, again, there is influx of fluid inside the brain cells. Whereas in your vasogenic edema, the influx of fluid is into the interstitial spaces. So when I say interstitial spaces, this will be between your cells. Okay, whereas in your cytotoxic, the fluid will be inside your brain cells. That's why cytotoxic, again, it is inside the cells. Now, to understand what would be the effect of your cerebral edema to the brain and consciousness of your patient. So, your cerebral edema would result to increase in your intracranial pressure. Okay, think of your Monro-Kelly hypothesis. Because of that, there will be decreased cerebral blood flow. Okay, the brain is getting enlarged, the brain is getting swelled. Okay, because of the edema, that would result to increased intracranial pressure. Because of that swelling, there will be an impingement, okay, or there will be an impediment on the blood flow going towards the brain. Because of that, that would result to ischemia and hypoxia. Now, the resulting byproducts of your ischemia and hypoxia will be your hydrogen ions and your carbon dioxide. And recall again, as I have mentioned, your hydrogen ion and your carbon dioxide are vasodilators. These are vasodilators with the attempt supposedly to increase the blood flow going towards our brain. But if we're talking about increased ICP and increasing blood flow towards the brain, that's aggravating our problem. Now, here comes your autoregulatory mechanism. Remember that once your ICP is increased, your autoregulatory mechanism will try to compensate. Your autoregulatory mechanism may cause vasodilation. Due to the vasodilation that your autoregulatory mechanism has resulted, it improved, it increased the cerebral blood flow. But the consequence is still increased intracranial pressure. So it's like a toxic cycle, okay, that would be aggravating the condition of your patient. If this is not managed, that would result to the worsening and deterioration of the condition of our patient. Okay, so as you can see, if this cycle would continue, it's just like the body is trying to help itself, but at the end, it's aggravating the condition. Okay, because all the while the body would think that it would need to vasodilate to increase the blood flow, but the increase in the blood flow would still increase the pressure inside the brain. So the remedy that we can have to resolve this problem is to really to decrease the edema. If edema will continue, there will be a continuous rise of ICP. The body would perceive there is decreased blood flow. Body would try to vasodilate, aggravating still the problem. Okay, so it's like a cycle that aggravates our problem. Now, if I would look at the laboratory for your patients with altered LOC, it could be your CT scan. Okay, since LOC or altered level of consciousness is an emergency, we always say that MRI would give a clearer image compared to a CT scan. But we always do a CT scan because it would give us a rapid result. Once class the CT scan is clear but still the patient manifests with signs of decreased level of consciousness, we proceed with MRI. Okay, we do an MRI. But for an emergency setting, it is CT scan without contrast that is done first. After which, you can proceed to CT scan with contrast. If still could not be found out, you can have your MRI to evaluate for tumors and lesions, which could also possibly cause your altered level of consciousness. Now, you also evaluate for the serum osmolality. Recall that once there is a problem on osmolality, fluid would be shifting between spaces. Okay, so your serum osmolality, once it is increased, could lead to the shifting of the fluid going towards the brain, or vice versa. Then you also have your ABG. Okay, recall that your ABG will be able to determine the hydrogen ion concentration in your blood. So what? So why do we need to find out the hydrogen ion concentration? Again, recall that your hydrogen ion could lead to vasodilation. And we don't want vasodilation in increased ICP because it would aggravate the increase in ICP. Now, lumbar puncture. Lumbar puncture may sound good. Lumbar puncture may make you think that, yes, I need that to diagnose the brain problem of my patient. But if your patient has an increased ICP, or even you are just suspecting an increase in an ICP, your lumbar puncture is contraindicated. Okay? Why? If you will be doing your lumbar puncture, you are freeing some space there in the spinal cord. That space being freed from the spinal cord would cause your brain herniation. Okay, picture a brain with an increased pressure and then there's a space down in the spinal cord. The tendency is for the brain to go down through the foramen magnum. Okay, class, we're talking about brainstem herniation there. And once brainstem herniation would occur, you think of your medulla oblongata and recall that your medulla oblongata would have your respiratory and cardiac centers. Okay, that would mean that your patient, okay, as what we usually say, you'll be sending your patient 6 feet below the ground if you will be doing your lumbar puncture once your patient have an increased ICP. So rule out first rule out first increase in ICP before you proceed with your lumbar puncture or before you allow the physician to go on with the lumbar puncture. Okay, let's go to your pharmacology or pharmacological management for increased ICP. Again, we treat the underlying condition. One is your osmotic diuretic followed by your loop diuretic. Now wonder, why do I need an osmotic diuretic and at the same time a loop diuretic? That would be two diuretics. Okay, why is there a need for us to administer two kinds of diuretics? Now, think that your mannitol is an osmotic diuretic. As an osmotic diuretic class, it would just pull out the fluid from the cerebral tissues, from the brain tissues, going towards your blood vessels or your intravascular space. That will be the work of your mannitol. Your loop diuretic, on the other hand, such as your furosemide, okay, would be the one to increase the secretion of your fluids through your nephrons, okay, through your loop of Henle. That's why the name loop diuretic. Okay, so again, mannitol would just pull out the fluids from your brain tissues going towards your blood vessels. It is your furosemide that would help excrete the fluid from your blood vessels going towards your urine. Now, you're administering diuretics. Recall your nursing intervention prior to administration of diuretics. You would need to check what vital signs. That would be your blood pressure. Okay, blood pressure. Because remember that your blood pressure is related to the amount of fluids that we have in our body. Also, since you're administering diuretics, what particular electrolytes do we need to watch out for? Okay, think of your sodium and potassium. Especially loop diuretics, think of potassium. Are we considering hypokalemia or hyperkalemia? You need to think of hypokalemia. That will be the risk of your patient who have loop diuretic administration. Now, mannitol. Mannitol is a very common management when it comes to neurologic problems. It helps with cerebral edema. It could also help with your hemorrhagic stroke, okay, and several other problems. Class, you need to be reminded that your mannitol has the capability or has the possibility, to crystallize. Okay, the preparation of your mannitol may crystallize over time. So if you will be preparing mannitol, you will be seeing white chalks there, class, on the surrounding. Okay, especially on the part where you extract the fluid. Okay, class, once the entire bottle of mannitol is crystallized, you are not supposed to administer it to your patient because those crystallized mannitol may be harmful already to your patient, may lead to emboli formation, and may risk the life of your patient. If there are few crystals, manufacturer instruction would say that mannitol could be immersed, okay, or mannitol could be thawed. When I say thawing, class, you can put it inside a container surrounded by a warm water or hot water for that matter, and then place mannitol inside that container. Take note, do not have the mannitol in direct contact with the hot water. There should be another container that would separate your mannitol from the hot water surrounding that container. Okay, once the crystal are removed, that will be the time for you to administer it to your patient. Okay, mannitol. You will be administering 50 ml of mannitol to 100 ml, sometimes even 150 ml, depending on the case of your patient. You might be tempted to use your Soluset or your volumetric chamber, or sometimes even your macroset. But class, your mannitol is administered directly IV push. So you need to use a 50 ml or a 100 ml syringe for that matter. Yes, there is a 50 and a 100 ml syringe that can be used. Okay, take note of that. Now, steroids. Among the causes there of increased intracranial pressure, your steroids will be the drug of choice if we're talking about inflammatory problems. Okay, inflammatory problems. Now, you might be thinking the most common steroid that you might have encountered is prednisone. Okay, your prednisone, which is used for the management of asthma. Okay, ladies and gents, your prednisone could not cross your blood-brain barrier. That's why the next drug of choice that you have is dexamethasone. Other than dexamethasone, we also opt for methylprednisolone. Okay, these medications, class, are intended to decrease the inflammation of your brain, to decrease also the swelling of your brain, because remember, your steroids would have anti-inflammatory properties. Now, antipyretics. Pyrexia is fever. And then recall earlier, I've mentioned that in stroke or increased intracranial pressure even, your patient's hypothalamus will be damaged. And your hypothalamus is your thermoregulatory center of the body. Now, thermoregulatory center. So class, the increase in temperature in increased ICP is not always about infection. It may be about hypothalamic damage. So you give your antipyretics. So how about if we don't mind the patient with increased temperature, since it's not about infection? If we will not be managing hyperthermia, class, recall again that your hyperthermia would increase the metabolic demands of your body. Once the metabolic demands of your body is increased, there will be an increased oxygen demand. Once increased oxygen demand, there could be decreased oxygen supply going towards your brain. And we don't want that to happen. Hence, even though if there is fever without infection, we need to manage the fever of your patient. Then we have your antacids. Okay? Oh, now wonder, we're talking about brain here. How come antacid is in the picture? Okay, class, don't think that antacids would go to your brain and cure something. There's no such thing like that. Now, your antacids, class, is given to address stress ulcers, which are common among patients with increased ICP. Yes, your patients with increased ICP has a high possibility of developing your Curling's ulcer. Your Curling's ulcer is a type of ulcer common among stroke patients. So that's why, class, we give your antacids. Later on, you will know PPIs are also given among stroke patients, okay, as a prophylaxis for this condition. So antacids, one example is your Maalox. Recall your Maalox is magnesium aluminum hydroxide. Now, still have your H2 inhibitors and your mucosal barrier fortifiers. The same purposes, class. Famotidine, tidines are H2 inhibitors, such as your ranitidine. And then, class, you have your mucosal barrier fortifier, sucralfate, also for the purpose of ulcer management. Then we have your barbiturates. Class, your barbiturates, such as your diazepam, are given among your patient who would manifest with seizure. So, will all patients with increased ICP manifest with seizure? That will not be the case all the time. Okay, so class, your barbiturates, such as your diazepam, okay, or your phenobarbital, I mean, for that matter, okay, barbiturates are phenobarbital. Okay, so barbiturates class or phenobarbital are given to prevent further occurrence of your seizure. Then we also have your anticonvulsant. Okay, common to anticonvulsant is your phenytoin or dilantin. So anticonvulsant, also an anti-seizure medication. We also have your vasoactive medicines. Class, your vasoactive medicines are medications that would increase the blood flow going towards your brain. Okay, but take note, you don't just increase the blood flow going towards the brain without first assessing the CPP of your patient. Yes, the cerebral perfusion. Okay, so you need to check for the MAP and ICP of your patient. That's why if you are in duty in the ICU, other than getting the vital signs of the patient, you would notice that there is another column there that would usually ask for the MAP. So you don't take the MAP, you are solving for the MAP, mean arterial pressure. Okay, now class, mean arterial pressure again is 2 diastolic plus systolic divided by 3. Now, let's have an example just for you to have a practice. If the BP of the patient is 120 over 80, okay, that would be 2 times diastolic. So that would give you 2 times 80, that's 160. Okay, 2 times 80 again is 160 plus 120. So that would give you 280. Then divide it by 3. That would give us a mean arterial pressure of 93. Okay, so you need to determine the mean arterial pressure of your patient because during the doctor's rounds, the doc will be checking for those. IV fluids. We are very careful in administering IV fluids to this patient. Isotonic IV fluids are recommended. Hypertonic IV fluids may cause fluid shifting, hence rarely recommended. Okay? However, class, if the cause of cerebral edema is identified, okay, a hypotonic or hypertonic fluid may be used to cause fluid shifting towards the intravascular space. But generally, we use isotonic fluids. Class, be mindful that we need to have this strictly regulated because any imbalance on fluid inside the patient's body may cause a cascade of activities that would damage the brain. Okay, so you don't just overflow your patients with fluids. If the IV rate class will be less than 60, it would be recommended for you to use your microset. Based on the patient's condition and assessment class, surgery may be recommended. So for the surgery, okay, you have your craniotomy or burr hole with drainage catheter in shunt in place. Then class, we may also have your craniectomy with resection. Okay, so class, for the surgery, again, there could be a craniotomy. When I say craniotomy, there will be a hole through the skull. And then in craniectomy, there will be a cutting of your, a part of your skull will be cut, okay, to release the pressure. Okay, either of these procedure class could help evacuate the blood, okay, from the patient's intracranial cavities. Okay, so this is your craniotomy with burr hole. So class, when you say burr hole, holes are being made through the skull of the patient. Okay, this is your craniotomy with shunt. So class, the shunt will be going towards, usually class, this is going towards your peritoneal cavity. Okay, so this is usually done among patients who have continuous increase in intracranial pressure due to fluid deposition. Okay, so class, the shunt is usually placed towards the ventricle, and then it may be going to other cavity of the body for drainage. Then we also have your craniectomy with resection. So class, your craniectomy with resection is done among patients, for example, with necrotic brain tissue. This is also done among patients with severe cases of cerebral edema, wherein class additional space is needed for the brain expansion. So in that case, class, now it may be possible that a part of the cranium or the skull is removed, and then later on, class, once the flap of the skin will be returned, you will notice that there is a depression here already. Okay, you will see patients later on, class, wherein you will notice when during head assessment that there is depression on the part of the skull. Okay, please be careful when you are palpating that because you might not be palpating through the skull. Okay, you might be palpating directly to the brain tissue of the patient. Now, you have your ICP monitoring. We've been talking about increase in intracranial pressure, but the big question comes in, how will I be able to know the intracranial pressure? So, class, your intracranial pressure is computed or determined, using your probes or devices which are inserted through the patient's skulls. Okay, skull, So you have the following options. So for the basic monitoring system, you have your intraventricular catheter, your subarachnoid screw, and then you have your epidural probe. Looking at those names, class, intraventricular catheter would obviously be inserted towards your ventricles. So in this case, class, that is inserted in the anterior horn of your lateral ventricle. And the usual site, as I have mentioned earlier, is the right side of your ventricles. Now, class, your ventricular catheters are capable of draining the CSF and at the same time measuring the ICP. Okay, so it has two purposes. It can drain your CSF and then measure ICP. Second, class, is your subarachnoid screw. Okay, so as the term implies, subarachnoid, so that will be below your arachnoid space. Okay, so class, recall that your subarachnoid is the space where your CSF would be flowing. So that would be also a good measure for your ICP. Then you have your epidural probe. Your epidural probe, class, so class, as the term suggests, your epidural probe would be placed above your dura mater. Okay, just like the epidural space that we've been talking about. Now, there is this new technique developed, which is referred to as intraparenchymal fiber optic ICP monitoring. Class, your intraparenchymal fiber optic catheter is used to measure your ICF without the need for CSF diversion. Okay, compared to the previous three that I've mentioned, which are more invasive. Again, the previous three are more invasive, class. Okay, this new technique has lower complication rate, lower infection rate, and no chance of catheter occlusion or leakage. Okay, class, when I talk about catheter occlusion and leakage, for example, in your intraventricular catheter, if your patient would be suddenly changing his position, there is a possibility that the catheter will be dislodged. Hence, it needs to be continuously monitored. Now, your urologic injury is minimized because of the small diameter of the probe. In addition to that, okay, the malpositioning of the transducer would have less impact on errors of measurement. Unlike your subarachnoid screw and epidural probe, okay, and intraventricular cath, once your patient will be moving, class, okay, once the tube will be occluded, the reading will be inaccurate already. Okay, however, this procedure is more expensive, and personally, I have not encountered this yet in the Philippine setting. Okay, so that is your intraparenchymal fiber optic ICP monitoring. Now, so these are again the methods for your ICP monitoring. So here we're talking about your ventriculostomy catheter, you're talking about subdural bolt, then you have your subdural catheter, your epidural transducer, and then the modern ones, you have your intraparenchymal fiber optic catheter. Okay, so this one is also the insertion of your ventriculostomy tube. Okay, I'm saying ventriculostomy tube if the purpose only of the tube is for drainage. But if it is for the purpose of ICP monitoring, so you have your intraventricular tube. Okay, so this is still more on ICP monitoring. Now, what are your nursing management? Okay, part of your nursing management is to perform neurologic assessment. So, class neurologic assessment, you will have your GCS scoring. GCS scoring of the patients are done every 15 minutes at least, and then if not, it will be done every hour. Okay, so class, if not, okay, if usually, in an intensive care unit, it is at least every hour. If not at least every hour, every 30 minutes. The usual struggle that you will encounter in the ICU is that you will have family members who will be complaining, why do you need to wake up my patient at night? If my patient is unable to sleep and then my patient needs sleep. Class, as nurses, it is our neurologic assessment that would take precedence and that would take importance when it comes to assessment of your patient. So you need to awaken your patient at night to do your GCS monitoring. We do not copy the GCS monitoring from previous shift because take note, the neuro problem of your patient can progress within minutes to hours. Your patient may be GCS 15 the last hour and then could be GCS 8 after 30 minutes. Take note of that. Now, although we are dealing with the problems in neuro system, our priority is still your airway assessment. Airway still is the priority. So do not be too focused on the brain without talking about your airway. So you need to consider your airway. For that reason, your patient's class with impaired neurologic problem would usually have your mechanical ventilation. Okay? Next to that is ensuring adequate ventilation. Now, positioning and moving. You need to properly position your patient. Okay? When you are moving your patient, you need to move your patient as one unit. Okay? You are not supposed to ask your patient to push up. You are not supposed to ask your patient to have their legs or foot placed at the end of the bed and then push up for them to be elevated. Your patient class must not exert pressure when you are positioning them. Added to that, Okay, added to that class, your patient must be positioned on a semi-Fowler's to high Fowler's position. The position or the purpose of your Fowler's position is to facilitate the drainage of your CSF. Class, the drainage of your CSF. Okay, the drainage of your CSF will be facilitated if the neck of your patient is straight in such a way that it would allow for jugular vein drainage. Okay, other than that, okay, you are not supposed to acutely flex the knees or I mean the neck of your patient. Okay, once you acutely flex the neck of your patient, meaning the head is bent forward, class, that would not facilitate CSF drainage. However, you need to be careful not to place your patient in high Fowler's position if your patient, okay, not to place your patient in high Fowler's position if the ICP is too high that you are exploring the risk for brainstem herniation. Because if the ICP is too high, okay, ICP plus working with gravity in high Fowler's position would help to aggravate, okay, to ensure in a bad way that there will be brainstem herniation. Okay? Then, other than that, you need to institute your seizure precautions. So when I talk about seizure precautions class, you need to have your padded side rails. You need to have something soft, okay, at the head of the patient, on the head of the patient, to ensure that the patient will not be banging his head in case of a seizure incident. Other than that, you need to prepare oxygen at the bedside if your patient still does not have oxygen supply. Other than that, you need to have your barbiturates and your benzodiazepines at the bedside. Remember that your benzodiazepines will be able to address or to halt the seizure episode, whereas your barbiturates will be preventing the future occurrence of your seizure. So for that reason, we need benzodiazepines combined with your phenobarbitals. Okay, or barbiturates, I mean. So class, take note ha, benzodiazepines and barbiturates. Again, benzodiazepines could stop the current seizure. Your barbiturates will be able to prevent or control the occurrence of the next episodes of seizure. Now, fluids and electrolytes. Strict MIO for your neuro patients. We do not estimate here. Okay? If you're talking about your nasogastric tube feeding to a patient with stroke class, you need to indicate the amount of the nasogastric tube feed that you have given to your patient along with the amount of water that you use to flush the tube. Other than that, if you are giving your medications, if you are giving your medications class through the nasogastric tube, one of your intervention is to flush before and after giving the medications. Class, for that reason, you also need to note the amount of fluids that you use for flushing the medications. That would ensure adequate or accurate MIO for your patients, because we don't want that our patient would manifest with intake versus output imbalance, whereas the patient would in fact have it equal if you are just accurately documenting it. Okay? Then emotional support. That's why class, even in the intensive care setting, there is a provision for the visitation of your significant others. By the way, for the electrolytes, be reminded of the normal values of your sodium and potassium. Okay? Particular electrolyte in the management of your neurologic problems. Other than that, okay, our goal in nursing care is to prevent sudden increase and decrease. Okay, we don't want the ICP to suddenly decrease. That is a big no-no for us. Okay, we don't want your ICP to suddenly decrease. Then we need to perform neuro assessment. And then, as I have mentioned, patency of your airway is still the #1 priority. Next, we need to address the elevated temperature. Class, elevated temperature, okay, again, is because of the hypothalamus. So we may be able to do your TSB, okay, then increase oxygen. Okay, for that reason, class, okay, we are increasing or we are administering oxygen through mechanical ventilation. Then, once there is brainstem compromise, you would ensure this by checking for the gag and cough reflex. So class, if there is no gag reflex, you're not supposed to feed anything by mouth. If there is no cough reflex, class, you need to be careful that your patient might have aspiration. Then, your patient, especially your patients who will be in ventilators, class, will be at risk for pneumonia. Okay? And then, class, for this pneumonia, you will be having a lot of secretions. Now, if there are secretions, of course, we need to suction the secretions, because if not, that would result to the desaturation of your patient. And as I have mentioned, your goal is still airway patency. Now, prior to suctioning, okay, just like other patients class, but with extra caution among your patients with increased ICP, you need to hyperoxygenate the patient. Okay, you need to hyperoxygenate the patient. Now, once that is hyperoxygenated or once your patient is already hyperoxygenated class, that's the time that you will be doing your suctioning. Okay? Now, how can I pre-oxygenate the patient? Okay, class, if your patient is intubated, we give 2 blows of oxygen or 2 blows using your bag valve mask. In other words, I will be compressing the bag valve mask twice prior to oxygenation. Okay? That would ensure that the patient had received a lot of oxygen prior to suctioning. So class, that's how we do it. Do not assume that since your patient is on mechanical ventilator already, that's already enough oxygen. Again, the term is hyperoxygenate the patient before suctioning. Why? When you are suctioning your patient class, you are not only suctioning secretions, you're also suctioning oxygen. Then, limit to 10 seconds. And if your patient has basilar fracture, think twice, think thrice before you do your suctioning. Once CSF leakage is still continuous, you are not supposed to do your suctioning class because you might be suctioning the brain tissues of your patient and not the throat of your patient or not the airway of your patient. When I talk about basilar fractures, these are fractures that can be found on the lower part of your brain. Okay? These are fractures that are found on the basal part of your skull. So class, once there is fracture, once there is basilar fracture, okay, once there is basilar fracture class, CSF leakage is very common. Okay? Later on class or ask me or tell me about your halo sign. Halo sign class is a sign that can be found on CSF leakage. Then, for the head of the bed should be elevated by 30 degrees. Okay, 30 degrees. Again, you don't want low Fowlers because it would impede the drainage of your CSF. You also don't want high Fowlers because of the risk for brainstem herniation. Okay, so we are into 30 degrees to 45 degrees semi-Fowlers for that matter. Then, you have your, so class, this is an illustration of your basilar skull fracture. As I mentioned, this will be a fracture on the lower part of your skull or lower part of your, brain. Okay, basilar base. Okay, so you can see here a fracture of the temporal bone. This is a fracture of your occipital bone. Now, nursing care again. So there should be alignment of the head and the neck. Okay, the alignment again of the head and the neck is needed for us to facilitate your CSF drainage, okay, through your jugular vein. You also would want venous drainage through your jugular vein. You don't want that class, okay, your CSF and then your venous blood to stay inside your brain because that would increase your ICP. Then you need to address or facilitate bladder and bowel distension. You need to check for that. Okay, the sensation of your patient is impaired in such a way that they may not be able to feel if their bladder is full, may not be able to feel if bowel is already full, so they don't have the sense or urge to defecate and urinate. So catheterization is usually done. Then for your bowel distension class, okay, evacuation may be done. Now, for position changes, as I've mentioned earlier, you instruct your patient, do not push up. Okay, your patient during moving up of bed shall not be the one who is exerting effort. Okay, a quiet environment is necessary for this patient class. Okay, why? Quiet environment is needed since your patient, okay, is at risk for seizure. A lot of noise class will be increasing the risk for convulsions for that matter. Now, you have your um, you need to avoid coughing, blowing of the nose, and straining. Okay, why? Coughing, blowing of the nose, and straining would also increase the ICP. Okay, for example, your straining class, your straining would trigger our Valsalva maneuver that would result in an increase in intrathoracic pressure. This would alter class your systemic and even your cerebral circulations significantly. So class, this is how, by the way, okay, this is an ICP monitoring device, okay, attached to the head of your patient. Okay, class, it's very crucial for you to ensure that this site is clean because class that would ensure or prevent the spread of your infection. Okay, major concern on a patient with invasive ICP monitoring class is that they will be at risk for infection. Then, part of your nursing care again due to the risk for infection, so that is brought about by your open head wound, you need to keep the dressing dry. and then the catheter dry. It's usually changed every 24 to 48 hours. But if the dressing is soaked, please do not wait for 24 hours. Change it right away. Then fever, again, could be infection or hypothalamus damage. Then you need to practice strict aseptic technique when we are talking about the care of your patient with invasive monitoring for your ICP. Now, the possible nursing diagnosis for this patient. Altered cerebral tissue perfusion. Why? Because your CPP is affected because of the increase in the ICP. Risk for infection related to the monitoring devices. Ineffective breathing pattern could be related to the brainstem compression or brainstem hypoxia. Ineffective airway clearance is related to the increase in the secretions, okay, due to the inability of our patient to excrete these secretions or to remove these secretions. This could also be because of impaired cough reflex. Sensory or perceptual alterations are related to the damage to the cerebrum. Altered family processes are related to the acute disease process or chronic disease process. Acute process class is stressful to your patient and family because it's sudden. Chronic class would cause burnout to your family because of the prolonged care that they are giving to their patients. Hyperthermia related to the hypothalamus damage or related to infection. Risk for injury class related to immobility. And then risk for fluid volume deficit. Other than that, I would like to add the risk for impaired skin integrity, which is a perennial problem in the hospital setting. So class, your risk for impaired skin integrity is brought about by immobility and can be prevented if you are just repositioning your patient every at least 2 hours. Okay, so class, take note, the repositioning of the patient is to prevent the occurrence of your decubitus ulcer. Okay, it's not just there to be intended as a nursing intervention, but it's intended to address the risk for formation of your decubitus ulcer. Other than that, okay, class, remembered impaired physical mobility. Since your patient would have impaired physical mobility, you need to perform range of motion exercises to your patient. You don't want your stroke patients to wake up with contractures. You don't want your stroke patients to wake up with muscular dystrophy because of not using their extremities. In other words, even if the patient class is unconscious, even if the patient's extremities are paralyzed, you need to do passive ROM exercises. So your passive ROM exercises will be able to help prevent class the complications of immobility, among which are your deep vein thrombosis. You also have your emboli, your pulmonary embolism, okay, and among many others. Okay, so this is your discussion in increased intracranial pressure. Now, class, our next topic will be on headache. I hope that these discussions are not giving you headaches. Okay, a break is suggested for you, class, after this video. Take some time before you proceed to the next one. Thank you very much for your continuous commitment.